Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, MRI contrast and the kidney. But before we get into that, make sure you check out the other videos at this channel. Check out my website, bcnephro.com, where you'll find articles not only on this topic, but on a wide range of nephrology subjects. I'm also on Instagram at bcnephro. Links to all will be in the description below. Now, let's get into it. I'm frequently asked whether it's safe to perform an MRI with intravenous contrast in a patient with kidney disease. This is a reasonable question, especially as iodinated contrast, that is the contrast that is used for CT scan or conventional angiography, is associated with nephropathy, acute kidney injury. I will link an article and a video on contrast nephropathy in the description below. But MRI contrast gadolinium is somewhat different. What is gadolinium? Gadolinium is a rare heavy metal that has paramagnetic properties. This makes it ideal for magnetic resonance imaging. Free gadolinium is inherently toxic. In order to decrease this toxicity and make it safe for intravenous administration, it needs to be chelated to an organic ligand. These ligands can either be linear or macrocyclic. Now, the first question is, does gadolinium cause nephropathy, acute kidney injury? And the answer to this question is no. Although there may be mild transient effects on GFR, these are clinically insignificant, and it is considered safe in this manner. For this reason, MR with gadolinium became the diagnostic test of choice as opposed to CT or conventional angiography in patients with chronic kidney disease, end-stage kidney disease on dialysis, or acute kidney injury. So what's the problem with gadolinium in kidney disease? With the increased use, a condition was observed called nephrogenic systemic fibrosis. Now, nephrogenic systemic fibrosis, also called NSF, is a scleroderma-like condition, although it's distinct from scleroderma, that manifests as skin thickening, induration, and discoloration. Now, this was debilitating enough, but it also was associated with internal organ fibrosis and often fatal. It was observed that most of the patients who developed this condition were dialysis-dependent end-stage kidney disease patients who had received intravenous gadolinium. It was also reported in patients with advanced kidney disease not on dialysis or patients with acute kidney injury. The hypothesis was, as gadolinium is renally excreted, the prolonged retention of this in patients with a decreased GFR allowed for dissociation of free gadolinium, which then could deposit in the tissues and induce fibrosis toxicity. So with this observation, the use of gadolinium became off limits in these patients. Subsequently, it was observed that the majority of cases of nephrogenic systemic fibrosis occurred with the linear type of gadolinium. A newer type of gadolinium with the macrocyclic ligand was developed, and this typically was not associated with nephrogenic systemic fibrosis. The observation being that the macrocyclic ligand was more stable and less associated with the dissociation and the free gadolinium deposition and toxicity. Now, the American College of Radiology subsequently grouped gadolinium based on the risk of nephrogenic systemic fibrosis. So group 1 agents, which were typically linear, have been associated with nephrogenic systemic fibrosis. These agents can be used in patients with a GFR above 30, but should not be used in patients with a GFR less than 30, end-stage kidney disease, or acute kidney injury. Group 2 agents, which are typically the macrocyclic agents, are rarely, if ever, associated with nephrogenic systemic fibrosis, and these agents are considered safe to use in these patients. There are also group 3 agents, which have not been associated with nephrogenic systemic fibrosis, although there is limited data. So out of caution, it is recommended not to use these agents either in patients with advanced kidney disease. This has led to a resurgence of the use of gadolinium in patients with kidney disease using these group 2 macrocyclic agents. Now, initially, out of an abundance of caution, it was recommended to perform dialysis after the gadolinium administration, certainly in patients who are already on dialysis. However, most recent guidelines don't recommend this as necessary. Of course, everything in medicine is a risk-benefit analysis, so we need to weigh the risks of nephrogenic systemic fibrosis, which is typically very low with the group 2 macrocyclic agent, versus the benefit of making the diagnosis with the contrast procedure. Now, finally, it has been observed even in patients with normal kidney function that gadolinium can be deposited in certain parts of the brain. This is referred to as gadolinium deposition disease. This is of unknown clinical significance, but has been observed specifically in patients who have received repeated gadolinium exposure, and is something to be aware of and proceed with caution until the clinical significance of this is better known. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Leave a comment or question below. Please share this video with someone who you think might be interested in learning about this subject. This helps get the education message across and helps the channel grow. And until next time.